and welcome to NOAA Rounds 5, Session 3. Please join me in welcoming our presenter, Ms. Erin Kirwin. Erin is a health economist here at the Institute of Health Economics and a PhD candidate at University of Manchester. I think she's fairly familiar to our NOAA community because she was one of the keynote speakers in our 2020 Alberta Health Economics Study Group meetings last year. She has extensive experience in using administrative data to inform public policy and over 10 years of working directly with administrative data, including her experience at Alberta Health, where others of you may know her from. She has led cost-effectiveness analyses to support decision-making for immunization programs such as COVID-19, HPV, and herpes zoster vaccine. Her peer-reviewed work includes cost of illness analysis, economic evaluations, as well as mathematical modeling of mitigation strategies for pandemic influenza and COVID-19. Her PhD research focuses on theoretic and applied methods for the economic evaluation of interventions with a very broad health system impact emphasis. And that's part of what she's going to be talking about with us today. Looking at the diagonal approach for economic evaluation of vertical and horizontal interventions in healthcare. And with that, I will hand it over to Erin.
Hi, so thanks for inviting me to present today. So today I am going to share the first chapter from my PhD thesis. And like Kate said, my thesis topic is economic evaluation for horizontal health system interventions. And this chapter forms the theoretic basis of my thesis. And then the next chapters are a little bit more empirical. So here's a quick overview of the presentation. I'm going to start with a brief introduction where I'll introduce some of the key terms. Then I'm going to go over some prior approaches that have been developed to address similar issues. There's 3 key papers to consider, and I'll go over the main contributions from each. Then I'll share a synthesized and extended model which builds from the 3 papers and addresses each of the challenges I identified in the background section. In the 4th section, I'll walk you through an example application of the diagonal approach, and then I'm going to close off with a discussion, including strengths and weaknesses and next steps. So there's 3 things that I'm aiming to cover in the background, and I'll start
Erin,
by yeah.
We're not seeing your slides.
Okay, let me go back to my presentation overview and share. Sorry about that.
No worries. I kept expecting them to pop up as you were speaking, and then it became crystal clear they were not popping up. So
got it. Okay. Can everyone see my screen now?
Can see it now. Thank you.
No speaking notes?
No speaking notes, just slides.
Okay, excellent. So what you can see now is the presentation overview, which I've just described, and then I'm going to go into the next section. So there's 3 things that I'm aiming to cover in the background. I'm going to start off by defining horizontal interventions. Next, I'll go on to discuss specific challenges related to the evaluation of horizontal interventions. And finally, I'll introduce the concept of the diagonal approach, which is what I propose to address the aforementioned challenges and what I develop in my thesis chapter. So you may have noticed the title of this presentation refers to horizontal and vertical interventions. So I'm going to define these on this slide. Typically, economic evaluations study interventions that target well-defined patient groups, disease outcomes, or care pathways, and these are often referred to as vertical interventions. Horizontal interventions are defined as anything that does not meet that prior definition, and often horizontal interventions are aimed at improving the overall structure and functions of the health system. Some other terms that have been used to define this concept are policy interventions, service interventions, or health system strengthening. So when you see any of those terms in the literature, in most cases, they're describing a concept really similar to horizontal interventions. And then what I think of as a critical characteristic for horizontal interventions is that they do not provide direct patient benefits. They have to be paired with or act upon vertical interventions in order to improve health. So for example, a workforce of highly trained nurses is a horizontal platform. Those nurses can't improve health by simply existing. They have to provide vertical interventions or direct patient care to actually improve population health. Other examples of horizontal interventions could be purchasing a new MRI scanner, expanding a clinic, or upgrading an IT system. So this is a diagram that was made by Richard Lilford, and I found it really useful to conceptualize the various points at which health system interventions can impact the system. So this diagram is a modification of Dada Bedian's causal chain of structure, process, and outcomes. So here we have structure, processes here, and outcomes right here. And you can also see that the diagram includes different types of vertical interventions. So while we have a horizontal intervention over here, these are all vertical interventions. So those are things like generic service interventions, targeted service interventions, and clinical interventions. So interventions on the left of the diagram are horizontal, like I said, and then as you move right, you get increasingly targeted vertical interventions. So I share this diagram to make the point that the defining characteristic or defining vertical and horizontal interventions isn't necessarily novel. The only change that I proposed so far is the use of the vertical and horizontal terms for those interventions. And also the other novel concept is the defining characteristic for horizontal interventions, which is not having a direct impact on health, but having to act or mediate vertical interventions. So there's many challenges to evaluating horizontal interventions. And as you can see, they've been noted by several different groups of authors. So I've classified the challenges into 5 categories, which you can see here. So the first is system level impacts. So horizontal interventions may shift the demand for or supply of services across service areas, thereby influencing equilibrium conditions. There can also be substantial externalities or spillovers to the system. There's also increased variability. So horizontal interventions have variable outcomes due to the context or organization in which they're implemented, and also due to the timing of their implementation. So the level of change achieved can be dynamic, temporary, and also subject to diminishing returns. Diffuse downstream effects. So horizontal interventions may impact patient outcomes through several indirect pathways. Many small effects through different causal pathways could lead to large impacts once you get to the system level. And the key difference between system level impacts and diffuse effects is that the former captures unintended outcomes, while the latter captures intended outcomes through many different pathways. Diverse outcomes. So due to the many potential causal pathways at play, a larger range of potential outcomes exist. So obviously outcomes are most easily compared if they're converted to a common measure such as the quality, but these conversions become increasingly complex as more outcome measures must be combined. So an additional challenge is to aggregate these outcomes without double counting, such as when totaling health benefits for multiple outcomes in overlapping populations. And then this diagram to the right is also from a different Lilford paper. And I think this diagram is a great illustration of how diffuse downstream effects work, where any single intervention, so here's the point of intervention, can impact many different outcomes through several different pathways. And the last challenge is constraints. So several authors discuss the dynamics of constraints on horizontal interventions. So most cost effectiveness analysis acknowledges a budget constraint, but the evaluation of horizontal interventions requires the consideration of constraints like workforce. So that could be the volume of people or people with specific skills, and also capital. So things like facilities, equipment, and data infrastructure. So to recap, all 5 of these challenges make horizontal interventions harder to evaluate than your typical vertical intervention. So one of the challenges that has come up a few times is which type of economic evaluation would be most appropriate for the evaluation of horizontal interventions. So I found it useful to evaluate this question relative to the 5 challenges of horizontal interventions that I just introduced. So you see these up here. The table interfaces those challenges with the different types of economic evaluation, where green cells indicate that the analysis type can address the challenge, and red means that there might be problems. So these 2 red ones here show main challenges, and these present in aggregating diverse outcomes. And this is expected since the main difference in all of these different types of economic evaluation is the measurement of outcomes. If, for example, we're trying to identify the optimal combination of vertical and horizontal interventions to implement, we need to be able to definitively rank these against each other. And therefore, we need to use an evaluation type that allows interventions with different target outcomes to be compared directly. So that's going to leave us with cost utility and cost benefit analysis. So now I'm going to introduce the focal concept, which is the diagonal approach. So the diagonal approach is a useful framework within which to consider the challenges of evaluating horizontal interventions. With the diagonal approach, there's an integration of prioritization and decision processes to simultaneously optimize and allocate resources between vertical and horizontal interventions. So most of the foundational work was done by Julio Frank and a small group of co-authors, and all of that work focused on health in less developed countries. So despite this initial focus on less developed countries, I think the principles could and should apply more broadly to all types of health systems. So to paraphrase the quote on this slide, what Julio Frank and his colleagues are saying is that we need to relax the false dichotomy between vertical interventions versus horizontal interventions, and we need to start considering them both at the same time, which is what Julio Frank calls the diagonal approach. So what I'm doing in my work is building from this concept and developing a mathematical framework to align the diagonal approach to the way that we think about decisions and optimization in health economics. So to develop the concept, I created a visual representation of the diagonal approach, which you can see here. So the vertical bars, these guys, represent vertical interventions, and these are supported by shared platforms and other horizontal interventions, which are represented by a series of horizontal bars at the bottom of the figure. The size of each bar in the figure doesn't necessarily represent the relative reach or value of each intervention, but the position and the color highlights complementarity between horizontal and vertical interventions. So these pink ones here are a little bit more associated with the horizontal platforms that are shaded pink, for example, different over here with the green ones. The layering of horizontal interventions at the base of the diagram demonstrates that multiple horizontal interventions can impact and support each vertical intervention. So for example, these interventions might be partially supported by more than one horizontal intervention or platform. The diagonal approach implies that implementation decisions for all interventions, so both vertical and horizontal, must account for the complex relationships between the two. If it's successfully applied, the diagonal approach should identify the optimal set of vertical and horizontal interventions to implement, and that's what I'm trying to illustrate here with this diagonal arrow that we're kind of integrating across the two different types of intervention. So another consideration is the unit of analysis or the resolution for the diagonal approach. I think it's quite flexible conceptually. So if you define horizontal interventions very narrowly, for example, if your unit of analysis is a hospital, like on the left of this slide, horizontal interventions are physical structures, specialized equipment like MRI and CT scanners, also our health workforce and subsets of that, and policy structures, for example, triage. And the vertical interventions are the different treatments and procedures that could be provided within the facility. So these are kind of fairly narrow interventions. We could get even more narrow to kind of like subsets of those intervention, like the anesthesiology, for example, associated with a total hip replacement. Or you could also use a really broad unit of analysis. So for example, all of the health services provided at different types of facilities in a region, and different facilities and programs within and across facilities would become your horizontal intervention. So here you can see some facilities and maybe some programs as well. And then you could use either very broad, so these are really broad categories for vertical interventions, or you could even borrow more narrow ones like from this column, and provide each of these vertical interventions on your horizontal elements. So of course, the examples on this slide are just illustrative and they're not comprehensive, but what I'm trying to show is that there's no single correct resolution to apply the diagonal approach at, and it's going to depend on the question that you're asking, the methods that you're using, and also the data that you have. The diagonal approach is more about considering the relationships between vertical and horizontal interventions and less about presupposing a resolution of analysis. So my paper has two aims. First is to bring together and synthesize prior theoretic developments for the evaluation of horizontal interventions that have been made to date. And the second is to extend these approaches and to develop a new theoretic basis for the evaluation of both horizontal and vertical interventions that's based on the diagonal approach. So mathematical programming or constrained optimization has been used in the past to articulate a lot of approaches that are quite a bit like the diagonal approach. So I identified three key prior developments that use math programming. So first we have Van Ball, Morton, and Severance, who developed an approach to evaluate how additional constraints, so things like constraints on the workforce or the platform capacity, would result in multiple shadow prices, which will impact the optimal allocation of a given budget. Morton, Thomas, and Smith developed an approach to determine the optimal level of investment in both vertical and horizontal interventions by increasing the efficiency of the supporting horizontal platforms. And then Hauk and a larger group of authors proposed an approach for decisions regarding the funding of new service platforms, and they aligned their approach to the two earlier papers. So their paper kind of brings everything together, and that's the last paper I'll talk about. So before I discuss constrained optimization approaches, I want to recap on the different ways cost effectiveness analysis decision rules are presented. So in typical economic evaluations, you're estimating the ICER, which is a series of pairwise comparisons. So we're going to talk about the equations on the left side of the slide first. So in this case, intervention 2 is currently in place and option 1 will be acceptable if the ratio is less than the value of lambda, which is generally interpreted to be either a willingness to pay threshold or the shadow price of the budget constraint. Increasingly, health economists are converting the ICER to net benefit. So under that framework, when there's multiple options, it's nice to move out of the pairwise comparisons by estimating the net benefit, the net health or monetary benefit, and then comparing net benefit values directly across interventions. And the second way decision rules are articulated is through constrained optimization, and that's given on this side of the slide. So here you define an objective function. So this is the objective function, and you maximize outcomes given a budget constraint, which is given here. So to do this, you decide which of the X interventions should be implemented, and the X's become your choice set. And because you have a defined budget, you can use the Lagrangian to estimate the value of lambda directly. So that's our shadow price of the budget constraint. There are some proofs showing that when the same budget and lambda values are applied for either decision approach and the conditions of perfect divisibility and constant returns to scale are met, either of these approaches would yield the same results. And there was a lot of really interesting work on this in the 90s. You can see all the references down here. So the work I'm sharing here uses a constrained optimization approach. So we're really working within the framework on the right hand of the slide. So now I'm going to go over each of the prior works. In 2018, Van Baal, Morton, and Smith evaluated the impact of budgetary constraints on the global optimum. Here we have the same basic setup where you're setting the choice variable X. So here's our choice variable X to select the optimal set of vertical interventions, which are indexed by I to maximize the sum of all the value of all implemented interventions. So here the maximization is subject to two constraints, which we can see here, O and L, which sum to the total budget. And one is for labor, that's the L, and one is for all other costs, that's O. So the author's main point is when there's more than one binding constraint, such that the Lagrangian would return multiple lambda values, you're going to have a suboptimal solution as compared to not having multiple constraints. So this is a pretty straightforward contribution, but I think it's also a really important one because we need to recognize that there will not only be costs associated with horizontal interventions to relax these constraints, but there's also the potential for substantial value in doing so. And we need to be able to think about capacity interventions as a part of our global optimization. Morton, Thomas, and Smith examined the optimal level of efficiency of investment to improve the impact of vertical interventions. So here, the V and X terms are mostly as before, and we're only dealing with one budget constraint. You can see that they've added this J summation, which represents all existing platforms, and Y is a decision variable for how much to invest in existing service platforms or how much to invest in the efficiency of those platforms. W is a scaling factor capturing the importance of the platform to decision makers, and gamma right here measures increasing or diminishing returns to scale. So through the application of one gamma value to all the platforms, the authors are assuming that returns to scale are identical for all platforms. And Haukadal presented a simplified version of the efficiency equation in their paper. And what they did is they dropped the W term and dropped the summation for the J term. So they only evaluated one program at a time. And finally, this is the paper that tied everything together. So Haukadal define a final equation for a new platform, which is given here. So in this equation, J refers to the existing platform and K refers to a new platform. A subset of all possible vertical interventions indexed by I can be provided on each platform, and some interventions may be delivered by both. So like Van Baal et al., Haukadal do not consider more than one existing platform in addition to the new platform. So you'll see that there's no J or K summation, it's just an index. So we're looking at sort of just a binary choice between the two. Like I said, Haukadal tie the three papers together by presenting their equation alongside the prior ones or modifications of the prior ones. And also in their paper, Hauck et al. Provide some examples to demonstrate the use of the three approaches, and I'll use and build some of their examples as a reference case in applying the approach that I propose. So in their paper, Hauck et al. Also proposed the following algorithm or decision flowchart that you can see here, which is designed to help choose which equation is the most appropriate for different decision problems. So I think this flowchart makes sense, but I note some problems when you consider the three equations as a set of alternatives rather than as a synthesized problem. So first, there's the challenge of interventions that impact more than one category. So for example, this could arise when investing in new diagnostic imaging equipment, which could require not only investment as included in the new platform equation, but also require new or redeployed health workforce to operate it, as in the capacity equation. Second, none of the equations capture spillovers. This was identified as one of the challenges of evaluating horizontal interventions, and I think this is a really significant gap. Finally, none of the equations consider time, which you could assume that time adjustments are embedded in the input values, but I think it's a really important thing to do to make assumptions about the discount rate and the time horizon explicit, especially because different horizontal interventions could have highly variable cost profiles over time. So my first step is to synthesize the three equations, and I'll just preface all of this by saying I know it's a lot of math here, so I'm going to try and pull apart the different parts of equations, but don't worry if you're not picking out every single term in these equations, because it's a lot to look at. So I'm going to use PowerPoint animations to show you what I'm doing step by step. So starting with the constraint equation as a base, so you can see these different highlighted things. You have three parts. You have your basic objective function right here, and then you have the two constraints, so 1 and 2, which sum to our total budget constraint. Next, we can add in the efficiency equation. So we get our W, our Y, and our gamma terms. We also have the J summation, so more like the original paper. And we also have the cost associated with the platform efficiency intervention. And then we add in the new platforms. So you basically mirror the terms in the maximization function, but for the new platform. And there's no K summation because Hauck only considered one new platform. So while there's a J summation on this side, no K summation here. So next, I'm going to point out a couple of problems. First, gamma captures returns to scale for all levels of I and J, and also doesn't estimate spillovers between vertical interventions. So I'm not sure gamma is really capturing the returns to scale that we need it to, because we also really want to think about spillovers. Next, K is singular, but it would be nice to compare more than one new platform option. And finally, it's likely that there would be more than one constraint in more realistic scenarios. So to address these problems, I made three main changes. First, I added a new summation for K so that multiple new platforms can be considered. One thing I know from my time in government is that decision makers are rarely making one decision at a time, so we need to let them think about several different options concurrently. Most importantly, I reformulated the value function, so that's what you see here. This is the value function in the brackets with a capital V. So I dropped the gamma and W terms to adopt a more general form that can capture both spillovers and returns to scale. As you can see, value is a function of the unique values of the choice variables Y for each platform and X for each platform and intervention, but also it's a function of the values chosen for all other interventions, which is really important for capturing spillovers. Finally, I wanted to generalize the constraints, as I'm sure we can all think of many examples where there'd be more than one constraint, such as different types of labor inputs. So this is sort of a generalization or extension of the labor and other input constraint. So now I'm going to share some applied examples. The first example demonstrates why the diagonal approach is required to achieve optimal outcomes. And the second example uses an app that I programmed in Shiny for R that gives a dynamic application of the diagonal approach. So this table is reproduced from Hauck et al. The purpose of the table in their paper was to demonstrate the use of the new platform equation, where the options are to implement a viral load testing intervention or an intervention providing oxytocin to people who have just given birth, and either separately in scenario A and B or together in scenario C. So separately here or here, and this gives the two interventions together in C. Each option requires the purchase of expensive cold supply chain equipment, and the only thing I've added to this table is the net monetary benefit, which is estimated with the threshold value from the Hauk paper of $200 per quality. So the main thing to notice here is that the fixed costs are constant between the three scenarios, and also the variable costs, qualities, and number of individuals accessing the intervention are the same across all three scenarios. So you can see here, these are all the same, and these values from when the interventions are provided separately map directly to when they're provided together. So Hauk uses the values in the table to demonstrate that using the new platform equation will help to identify the optimal bundle of interventions between these three scenarios. And as I said, I think it's pretty important to think about the way that equal fixed costs are introduced, and it's a pretty strong assumption. I don't think it's very likely to hold. Either there's a scale property to the physical structures for the cold supply chain, or there would be fixed staffing costs that are unlikely to be exactly the same across the scenarios that they presented. So I don't think the assumption of constant fixed costs is plausible. So instead, let's consider the case, which I present as option D right here, that the new platform could not support full implementation of the oxytocin intervention, and that only the most accessible of 5,000 patients could be reached without increasing the fixed costs, and that each of these patients have an average incremental net benefit of 3 qualities. So in this case, with a more realistic scale assumption, the net monetary benefit is negative, which you see right here, and it's not nearly as cost effective as before. So next, let's consider a scenario where the capacity of the new platform is increased. So that's done here where we increase the fixed costs, but this could also mean that we have more capacity and we can provide both interventions as before. This results in a positive net monetary benefit. So without jointly considering platform capacity alongside investing in new platforms, the incremental net monetary benefit of 3.8 million wouldn't be realized. So this demonstrates the need to consider multiple types of horizontal interventions simultaneously through the diagonal approach. So now I'm going to expand on this example, and I'll do that by considering 3 different platforms, each of which are also based on examples from the Hauk paper. So platform 1 is a rural facility, and it provides primary care and acute services. So it's one platform, and it has 3 different interventions. Platform 2 is a workforce of nurses skilled at chronic disease management, and they are deployed across facilities, and they provide 2 different interventions. And then 3 is the same new platform that we considered before, so you'll recognize these interventions. And then you can see in the right columns of the table that there's different horizontal interventions available to each platform. So based on the setup, I used values from Hauk as input values, and I made functions to calculate outcomes for different combinations of options. Then I took those values and I programmed them into an app, and you can see the interface for the app right here. So you can go into the app and change the budget, which is this one right here, the labor constraint, time preference rate, time horizon, threshold, and the sets of horizontal interventions and platforms that are available. So this is all programmed so that costs and benefits are functions of these inputs. So everything's going to respond to whatever scenario you set on this side of the panel. And then the app returns the optimal set of interventions to fund, and will also tell you the total cost and net benefit. So we're going to get these little fund indicators next to the combinations that are optimal, and then the total net benefit and total cost. So you can check out the app at this link, and if we have time at the end, I could also do a live demo. So now I'm going to share results that I generated using the app. So you have different scenarios. We have A, B, C, and D, and you have different total budgets. So here's the budget column, different labor constraints, and then we have different combinations of funded vertical and horizontal interventions on each platform. So you can see the platform numbers here. And finally, we have total net benefits on the final column. So the results in this table are designed to demonstrate that with stronger constraints, net monetary benefit decreases. So for example, with higher constraints in scenario B and D, we see that we have a lower net monetary benefit. And also when the budget decreases, like in options C and D, net monetary benefit decreases as well. So this is just a really basic set of results to show some face validity with respect to changes in total budget and constraints. And these results show that everything is working as it should, but there's nothing groundbreaking here. So then this next set of results are designed to show what happens when the budget is held constant, but only some types of horizontal interventions are possible, and also show what happens when we vary the labor constraint. So on the left panel, the budget and the labor constraint are constant, but you can see the only case And then you can see here that we're varying the types of horizontal interventions that are possible. So all of them are possible here, and then just kind of pairwise sets where we exclude one type of horizontal intervention. You can see the only case where the types of horizontal options evaluated doesn't make a difference is when the capacity intervention isn't allowed. And that's because when the labor constraint isn't binding, you don't need to implement interventions to relax it. So that's why this combination is the same as all, and there's no reduction in net monetary benefit. And then when either the new platform or efficiency intervention, like G and H, isn't allowed, you get a worse net monetary benefit. On the second panel, we have a 50% maximum on capacity, so the labor constraint is binding. And here you can see outcomes are substantially worse compared to the left panel and the example where all options are available. So finally, there's a third example to demonstrate the inefficiency that arises when you consider each type of horizontal intervention in a stepwise manner as suggested by this diagram. So here I considered each of the platforms in turn, allowing the most efficient horizontal intervention to be implemented for each platform. So in the first scenario, which is scenario M, the total net monetary benefit is $92 million, and that's $13 million less than with the diagonal approach. And then in the second scenario, the labor constraint is binding, and the net monetary benefit is reduced by an additional $25 million. So in the discussion, I'm going to go over the strengths and limitations of my approach, plans for future research, and policy implications. So here's a listing of the strengths and weaknesses of the diagonal approach, which I propose. I set these against the 5 challenges associated with horizontal interventions that I shared at the start of the presentation. So for system level impacts, the terms included in the value function should be used to address things like spillovers. I don't articulate the functional form of the value function in this paper, and I see that as a strength because I think the included terms have really important implications on their own, but the functional form of the value function is definitely an area for further research. And we don't necessarily have the right data to estimate the value function yet, but hopefully by defining it, we might actually start to think about collecting that data and how we might estimate it. For increased variability, just like for regular economic evaluations, you should apply probabilistic sensitivity analysis to the diagonal approach so that the credibility intervals, et cetera, can be estimated. This might be really computationally intensive, but I don't think that's necessarily a limitation. Defining how to do the PSA for the diagonal approach is out of scope for this paper, but I think it would be important to do. For diffuse downstream effects, these should be fully captured in the cost and value inputs for the full range of relevant horizontal and vertical interventions, but there are the same empirical challenges as for system level impacts. Diverse outcomes, this isn't a problem for the diagonal approach theoretically, since all values and costs are estimated in the same units, and that's done by converting quality to cost. Again, you'd run into the empirical challenge of estimation, but that's not a theoretic challenge. Constraints. So multiple constraints are easily captured within the overhead and end summation terms. The limitation is, again, empirical estimation. So to summarize, from a theoretic standpoint, the diagonal approach addresses each of these challenges. With the exception of increased variability, there are empirical challenges in estimating the value function and for estimating costs. So there's some other strengths and limitations beyond those in the prior slide that I want to discuss. So as I said earlier in the presentation, when I introduced the diagram for the diagonal approach, which is included here for your reference, the approach can be applied to different units of analysis. I think of this as a strength more than weakness, but there could be challenges in defining things empirically where different units of analysis would require different types of assumptions. The scope of analysis is also challenging, and you'd have to think about how reasonable it is to make simplifying assumptions, such as ceteris paribus with the diagonal approach. So this is really talking about, are we doing local optimization at a smaller scale, or are we looking at a fully kind of like global optimization, recognizing that local optimum is rarely the global optimum. And then finally, I want to state that I don't think we're even marginally close to widespread application of the diagonal approach, especially on a total healthcare budget allocation, but that's not an aim or a goal that I set for myself within my PhD or kind of like within this study area initially. The point of the chapter is to move us closer to this in the future by refining the constrained optimization problem. But I think to make a strong case for the collection of the data and the development of the methods to support empirical applications of global optimization, or the diagonal approach, we may need to be thinking about the problem really clearly. And so that was my main aim, to improve the theoretic basis. So future research that I'll include in the chapter is, as I've discussed at length, the need to generate the data and develop methods to estimate things like the value function. And then I also see some opportunities to extend the approach and to make it even more complex. So maybe thinking about stratifying the target population as an additional subset, subscript even, or we could start to think about the need for services by comorbidity or access to services by geography. But this would be a very complex addition to an already complex system. So at this point, I'm a bit hesitant to do so. And then we can also think about different aspects of care provision, like coverage, eligibility, and copays. And this has actually been suggested by Jessica Ochelek and colleagues in their own constrained optimization paper. So you can kind of see what they're optimizing across in this diagram. So in terms of what the diagonal approach equation means for policymakers, I think there's a few takeaways. One is that the dynamic example highlights that outcomes cannot be maximized unless all vertical and horizontal interventions are considered simultaneously for budget allocation decisions. The example also shows that the diagonal approach will achieve better outcomes than stepwise algorithms like suggested by Hauk et al. We also know that by design, the diagonal approach is better at addressing the challenges related to evaluating horizontal interventions. And finally, it's clear that the optimal outcomes are achieved when a broad, long-term, and dynamic approach is implemented. So that's it for my presentation. Thanks again for joining, and I'm looking forward to your thoughts and feedback.
Thank you, Erin. And we'd all do applause if we were not online. I encourage folks to use the question and answer box. It's in the bottom or elsewhere if you're not using the desktop version of Zoom, and we will roll through some questions for our remaining time. So first question says, thanks for the great presentation. Around the scope of analysis, do you have any recommendations for how you define boundaries around what is included in the diagonal approach, what vertical and horizontal interventions?
It's a great question. I think it's so specific to the type of analysis you're doing that I'd hesitate to define it really concretely. But I think a good signal or a good place to start looking would be the budget that you're working with. So for example, if the decision maker and their scope of analysis and the budget they have to allocate is at a regional health system level, that's probably most appropriate to optimize, unless you can convince them to go up a level and you also have the data to go up a level. So I think I'd start by looking at the scope of influence the decision maker has and the budget they control.
Yeah, that makes sense. And that would be pretty situationally dependent. Yeah, that it might be the dream to go as high up as possible and optimize all the things, but more actionable if it's in the scope of influence. Cool. Mm-hmm. Okay, just waiting for another question to pop up. There's one from Andy Chuck. Hi, Andy. Thanks for the talk. Haven't seen this much Greek in a long time. It was nice. Question one, how much of an issue is the constant returns to scale assumption in terms of applicability of the method? I kind of had that question too.
Yeah, so I think that's one of the main challenges that this approach actually addresses. So I'm going to go back a few slides just to make this super concrete. Now look at that Greek that Andy likes so much. Oh man, okay, here we go. So the value function is basically, I'm not specifying the form or how the spillovers work. All I'm specifying in this case is what the terms are. So here we have our X variables. So those are the vertical interventions. Here we have our horizontal interventions. And then we also have all the X's and Y's for all the other existing platforms and interventions that are implemented. So here we're completely relaxing the idea of constant returns to scale. One point that I may not have addressed quite clearly enough is that we're working in, I suggest, an integer programming framework. So we're making binary choices rather than, linear choices where we'd be saying, this is we're implementing this at a 0.5 value. So how you work around that to get into constant returns to scale is you'd specify lots of different iterations of the same decision, like the same decision implemented at 50% versus 100%. And then by, stratifying that way, you're going to capture the constant return or non-constant returns to scale.
Okay, cool. Yeah, that's an interesting workaround. So second question, you mentioned potentially, in quotes, directly applicable. Could you elaborate on why potentially?
Potentially directly applicable. Sorry, can you?
I'm not sure that's what I've got. If that is not crystal clear, Andy, can you clarify a tad? Okay, we'll move on to the next one if we get a clarification on that. Oh, it was on the slide where it said potentially, is what Andy says.
Okay, the slide I was just on.
Maybe. It's not that one. We'll figure it out.
Back to it.
To roll along. Oh, it was in your summary slide on pros and cons.
Okay. Let's see. So the possibility for direct application, that's probably it.
Yeah.
So I guess what I was trying to say here is that I don't think that we're anywhere close to doing a global optimization for the Alberta health system or any other health system yet. The purpose of this work and why I think it's important is because we really need to think about the decision problem. It's not just a matter of like optimizing across a defined set or a short set of vertical interventions. We need to think about how we're developing the system to support it. So things like Connect Care at Alberta Health Services are a great example of that, where maybe we haven't conducted at least a published cost effectiveness analysis, but it has so many downstream effects and so many implications for other parts of the system that it's actually a really important intervention that impacts everything. So unless we're thinking about things the right way, we're not going to make the optimal decisions, whether respect to horizontal or vertical interventions.
Okay, great. Next question. Says, thank you, Erin, a great presentation. I appreciate that we are far from using this approach in practice. I'm wondering what could be some of the first steps to start moving in that direction.
So I think the best first steps would be to start looking at it in smaller problems. So even though I made the critique that local applications, local optimizations are not necessarily going to be global optimizations, I think we need to start building that capacity and the tools and methods by applying it to small scale problems. So maybe looking at sort of defined care areas or like singular horizontal platforms, and then the interacting vertical interventions associated with that. I think that's a good way to start. In terms of methods, I don't think we're restricted. We could look at, decision modeling methods, so like really model-based analysis. We could also, if we had good enough data, start to look at econometric methods. The challenge will, of course, be the outcome measure because we don't necessarily have great proms. But if we're able to look at something more general like mortality, that would be one way to start.
Cool. That is the questions I've had now. If anyone else has a question, please add it to the queue because we do have time to have some further discussion. Just give folks a minute if they're going for that Q&A button in the Zoom. Okay, it looks like one more. Request for a non-Greek version in the future. And then kind of feeding into a question of, at the layperson level, what does this do that is a net advantage over our existing approaches? What do we get to going about it this way rather than using previous methods and approaches?
Okay, thanks for that question and noted. I'll try and figure out some sort of like thought bubble way to present the equations. So from a lay perspective, why would we do this? We do this so that we're thinking about the scope of analysis correctly. So for example, if we're only looking at optimizing the set of interventions that are provided in a hospital, but we're not thinking about the horizontal platforms associated with that. So things like the equipment in the hospital, the policies in place in the hospital, the people available to work at that hospital. We're not actually thinking of the full set of things that we have control over. So this is a theoretic framework to make sure that we're thinking about not just those vertical interventions, but the horizontal interventions as well. And by using this, we're going to have optimal outcomes or better outcomes for the whole population.
Great. Another question. Do you think there is a specific area of health and healthcare that needs this approach more urgently than others?
That's a really interesting question. I mean, any super unperforming part of the system generally. I would think about areas where there's not a lot of evidence first. So I think one area that there might be a lot to do would be physician compensation. We provide fee codes and fee modifiers that allow physicians to bill for different services. But I don't think in general, Canadian health systems have looked very closely at how those combinations of codes and incentives influence health. So I think that could be a really interesting thing to look at.
That is interesting. I mean, when you mention codes, would something like modifiers for complex patients be kind of in that arena that you were thinking about?
Yeah, that's definitely in the arena of things I was thinking about.
Okay, cool. Any additional questions? Okay, that was a pretty good round of questions, and Erin had left us a lot of time for Q&A. So if nothing else pops up, I will go ahead and end the session. Thank you everyone for joining. We do have another installment of rounds coming up in December, speaker to be announced, I believe. And you can visit the NOAHE.ca website for more information on that and to register to hear about future events and such. Thank you. Thank you, Erin.
Thanks.